There we go. Good afternoon, everyone. Glad to have you all here. I hope you all saw the screen with all the usual housekeeping notes about muting, closed captioning, using the chat feature, and I see our speaker is ready to go with her slides. That's fantastic. Just before we start, I'll tell you one other thing, and that is greetings from California. If you can see my background, this is one of Zoom's canned backgrounds of the Golden Gate Bridge, but I also happen to be in San Francisco right now as we speak. So perfect timing. I'm here for a conference about our ADNI study, which is looking at brain imaging. So by next time I see you, I'll have more information to share about that. But we'll put that off to the side because the topic of today is our menopause and cognition study. And I'm very happy to welcome and introduce Dr. Amber Watt as our presenter for today. Dr. Watts has a PhD in gerontology from University of Southern California in my hometown. So all kinds of great connections here today. She also has a master's degree and a bachelor's degree in psychology. Dr. Watts is an expert on aging and cognitive health. So that's one of many reasons we're happy she's here. And she promotes the health and well-being in midlife and older adults, and is especially interested for today in women's health during menopause and the menopause study. One more point of personal privilege. Not only am I happy to have this topic on the webinar today, I am also participating in the menopause study. I can say that, I can reveal my own participation. And it's been really fascinating for me to have participated for so many reasons, learning about how clinical trials or research work and hopefully learning about my own cognition. So anyway, enough about me. I just want to express how happy I am to have this study and to have Dr. Watts with us today. So Dr. Watts, welcome, and I will turn it over to you.
Thanks so much, Kelly. Is everybody able to see my slides here?
Looks good.
Perfect. Thank you so much. All right, great. Well, I appreciate being here with all of you. Thanks for coming. And as Kelly said, I'm going to talk about menopause and cognition, which is related to a study that's ongoing right now. I am a faculty member in the Department of Psychology on the KU campus in Lawrence, but I've also been a longtime research fellow with the KU Alzheimer's Disease Research Center. Here we go. So you may not be aware of the fact that women have 2 times higher risk of developing Alzheimer's disease than do men. And part of the reason for this may be related to changes occurring during the menopause transition that put women at greater risk of particular cardio and metabolic diseases that increase the risk of Alzheimer's disease. So brain changes associated with Alzheimer's disease appear 15 to 20 years prior to the symptoms of Alzheimer's disease when people come in and get a diagnosis of Alzheimer's disease. So if the typical age of being diagnosed is 65 and you count backwards from there, 15 to 20 years, what's happening during that midlife time period for women is menopause. So midlife is really an optimal time to focus on for trying to understand what's putting people at an increased risk of developing Alzheimer's disease later. And there are some female-specific cardiometabolic changes that emerge in midlife that are exacerbated by the menopausal transition, which occurs in 1.5 million American women each year. And when I say cardiometabolic, I'm referring to things like heart disease, diabetes, obesity, and things like that. So all of those things put women or put everyone at increased risk of Alzheimer's disease, but this starts happening at a more advanced rate in women during that menopause transition. Yeah. So I just want to introduce a little bit what menopause is, because it's the more and more I get into this subject, the more I learn that most people aren't really that familiar with information just about the definition of menopause, what it is, what happens to people when they're going through it. So the definition of menopause is when a woman has gone 12 months or more with no menstrual periods. And this happens at an average of age 51 in the United States. What a lot of people are less familiar with is the idea of this stage of perimenopause, which is the period that happens before you've gone 12 months without a menstrual period. And that period lasts on average of 5 years, and for some people, as long as 10 or more years. And it's interesting that there's very little research and knowledge about menopause because the average woman spends a third of her whole life in the postmenopausal period now that people are living so much longer. So it seems very important that we would understand what this period means for people. Of course, the traditional symptoms that we associate with menopause are what we call vasomotor symptoms, so hot flashes and night sweats. And for people who experience those, they can last anywhere from 3 to 10 years. So you can understand how inconvenient and troublesome that can be for people. But what you may not know is that having hot flashes and night sweats, especially severe ones, is associated with greater chronic disease risk. They can be successfully treated with estrogen therapy or a new alternative medication that isn't hormone based for people that are not good candidates for hormone therapy. But we know that a dramatic drop in estrogen, such as what happens during the menopause transition, is critical for both brain and heart health. So these are important features to understand about menopause and why this is related to Alzheimer's disease and cognitive changes as we get older. So we tend to think of estrogen as something that regulates reproductive health, but you may not be aware that estrogen is actually really important to the brain. Estrogen is the master regulator of the female brain, and it's important for keeping neurons, which are brain cells, healthy and active. Estrogen protects neurons, it boosts the immune system, it allows new neuron connections to be built, promotes the release of chemicals that regulate mood and pain sensations, and increases blood flow to the brain. All of these things are important for understanding why women's health starts to change when they go through menopause. Estrogen is also really important to vascular health. And we know that vascular health is not just about the brain, but not just about the heart, but also the brain. The brain is a very vascular organ. So if you look at this picture here, you see, usually when we picture the brain, we just see this squishy pink tissue. But there's actually all of this microvasculature that is very important for keeping the brain functioning. And estrogen is also important for that vasculature in the brain. Women's risk of heart attacks and strokes increase dramatically after menopause because of their relationship with estrogen. Estrogen supports vascular health because it reduces substances that narrow the arteries, it reduces inflammation related to narrowed blood vessels, and it increases blood flow to the brain. And one of the things that we see as women go through menopause is changes in the amount of blood flow to the brain. Another interesting feature of menopause, we always think of hot flashes and night sweats as the things that we associate with menopause, but you may not be aware that the majority of women as they go through the menopause transition also experience cognitive symptoms, things like forgetfulness, poor concentration, or sometimes we call it brain fog. It's just kind of general, my brain's not working as well as it usually does. And this happens in 40 to 60% of women as they go through the menopause transition. A lot of women report that they feel like they're losing their mind, and when they go to talk to their doctor about it, they really don't get any great answers. But it's important for women to understand that these are real. It is reflected by cognitive test scores and brain imaging. And it may be the case that a lot of healthcare providers are not familiar with this symptom, so that when women go into the doctor and complain about it, they may hear, oh, well, you are just not sleeping very well, or maybe you need some antidepressants. But these cognitive symptoms are real, and they are related to this process of the menopause transition. And they are very bothersome, both at work and at home. There's some research showing that women lose a lot of work productivity because of these changes that are happening in their brain. So the question is, should I worry if I am having menopausal cognitive complaints? Is this going to lead me to develop Alzheimer's disease? So the best answer I can give right now is that there's not really a very clear association. We need more research to understand how these things are related. We do know that the cognitive complaints are most common in the early perimenopause stage, and in some studies they appear to rebound later in the perimenopausal transition or postmenopause. So the good news is, for a lot of women, these symptoms do improve toward the end of the transition. And the symptoms that occur during the transition are unlikely to indicate clinically significant cognitive impairment. And there hasn't been any evidence that these symptoms are directly associated with later dementia risk. But what's really important for us to understand is that these cardiometabolic risk factors are associated both with more cognitive complaints in the menopause transition and associated with Alzheimer's disease risk later. So it's really important for us to understand what to do about these cardiometabolic risk factors that are leading to these variety of cognitive symptoms. There's been a few neuroimaging studies in menopause that show noticeable differences between pre and postmenopausal women's brains and compared to men's brains at the same ages where women are going through the transition. And those changes include reduced brain glucose metabolism. So glucose is the fuel that our brains use. A shrinking hippocampus in midlife. So hippocampus is an area of the brain that's associated with memory formations, which we know is very important in Alzheimer's disease. Also increased accumulation of amyloid plaques, which is one of the key hallmark pathologies of Alzheimer's disease, and changes in memory tests that are responsive to estrogen. So this is one of the reasons why we think that women are at increased risk of Alzheimer's disease compared to men, particularly as they are going through this transition. So you might be wondering, if I am at risk of this, what can I do to reduce risk? And this is the case for all people, not just for women or not just for people going through menopause, but we can treat and prevent a lot of those cardiometabolic risk factors like high blood pressure, high cholesterol, diabetes, obesity, depression, and sleep problems. Many of these occur more frequently in women, and some of them occur more frequently in women after they've gone through menopause. And of course, as if you've been to other presentations at our Alzheimer's Disease Research Center, you've probably heard the messages a lot before about health behaviors. So not just medications, but healthy behaviors like exercise, diet, weight management, stress reduction, and reducing or quitting alcohol, smoking, or other substance use. So these are all behaviors that reduce these risks, both during the menopause transition and later in life when we are thinking about Alzheimer's disease. I do want to mention, some people ask me, okay, well, should I then take hormone therapy if I'm worried about Alzheimer's? I want to make sure that you know that hormone therapy is not recommended at any age to prevent or treat cognitive decline or dementia. However, it can be very useful in specific populations. So for example, women who go through early onset menopause. So premature menopause is when menopause occurs prior to age 40. Age 40 to 45 is considered early menopause. And then there are also about 5% of women who go through natural early menopause. So for women who have these situations, hormone therapy may be valuable for them because their body is losing estrogen earlier in life compared to people who go through natural menopause. Another important group to think about is people who undergo surgically induced menopause. So that's people who have their ovaries removed, especially if that happens before the age of 45. And a lot of research has suggested that using hormone therapy in those cases can improve cognitive symptoms and other symptoms those women may have. Also, some people who go through chemotherapy for cancer treatment may also have early menopause. And for those women, hormone therapy is also considered beneficial to their cognitive function. So just to introduce the Menopause study, we are still collecting data. We have about 20 people who are currently enrolled. Our goal is to get to 150 people. And we are looking to recruit women who are near or around the menopause transition, so ages 40 to 60. We will take women anywhere from they've just begun having changes in their cycle to women who are less than 6 years post-menopause. And we're particularly interested in women who have risk factors, those cardiometabolic risk factors I talked about, like high BMI, high blood sugar or cholesterol, high blood pressure, or a history of smoking. And participating in the study includes having your blood taken, wearing a wrist monitor for 7 days that measures your physical activity and sleep. These women fill out surveys about their sleep and their experience of hot flashes, and then they take some cognitive tests to help us understand how their cognitive function is doing. There is a web link here. Hopefully you can use this, or maybe someone can throw that in the chat so that if folks are interested in learning more about participating, or maybe want to refer a friend that might be interested in this study, we are very grateful to have people volunteering to participate in this study. So a quick final summary is that Alzheimer's disease risk is higher in women, and that menopause is a critical period to reduce risk for developing Alzheimer's disease because of those cardiometabolic risk factors. It's important to treat, manage, and prevent those related risk factors like vascular, metabolic, and hormonal risk factors. And we can do some of those things through lifestyle habits like exercise, diet, and sleep. to help reduce risk. And that's true for everyone, not just for people going through menopause. So I want to go ahead and introduce a couple of helpful resources if you want to learn more about why and how women are at higher risk of Alzheimer's and what people are doing about that. So there is an organization called the Women's Alzheimer's Movement that has a great website. They have a helpful newsletter that has a bunch of information about women's risk of Alzheimer's, and also the Menopause Society if you want to know more about menopause in general. There's some great books on the subject. One is called Estrogen Matters. So you may have heard in the past that there was a lot of controversy about whether or not hormone therapy was safe. A lot of the research that spurred that debate is more than 20 years old now, and it's been discovered that there are a lot of problematic issues that people took from those findings. So this book, Estrogen Matters, goes into a lot of detail about what we know about hormone therapy now. There's another book called The XX Brain, which is all about how women's brains are different from men's brains. And a new book called The Menopause Brain, which is all about what happens to the brain as people are going through menopause. Also, this link here at the bottom is patient information for people who are experiencing brain fog and memory problems in the menopause transition. And so this is also a really useful web link to check out if you have questions about that. Let's see. I want to acknowledge my funders and the Alzheimer's Disease Research Center and open it up to questions. Usually people have a lot of questions about this topic, so I wanted to make sure I wrap up a little bit early to give people time to get their questions in. And I can go ahead and stop sharing and make time for questions here. I see some things popping up in the chat.
Yes, thank you, Dr. Watts, for your presentation. Fascinating. Took lots of notes. And there is a question in the chat. If you can see it and reply to it, that would be great, about why hormone replacement is not recommended, etc.
Yes, that's a great question. So there's a lot of controversy about hormone replacement therapy. And it is helpful. Right now, it is FDA approved for the successful treatment of hot flashes and night sweats. It doesn't necessarily fix all the other problems. It is useful for those issues. Part of the reason is that the timing of it really matters. And when people take it later into older adulthood, it can actually be harmful. So if people are taking it, past 60, 65, 70, it can actually increase some other disease risks of things like heart disease. So it's really not appropriate for everyone. There is still a lot of controversy about what it's useful for, what it's not useful for, who it's harmful for. It isn't in itself the cause of the problem. The problem is that when we reduce estrogen, we see a lot of dysregulation of these other cardiometabolic systems, and it kind of interacts with the aging process. So it's not the case that if we just introduce estrogen later in life that it will fix those problems. So it's not that menopause or loss of estrogen is the cause of the problem. The issue is that it's related to a bunch of other cardiometabolic risk factors that we need to be paying attention to. Does that make sense? I hope that helps. And there have been studies, by the way. So they have done a lot of studies about whether taking hormone therapy can prevent Alzheimer's disease. And it's really the majority of research suggests that if people take it during the menopause transition, it can be beneficial, but not if they take it long after the menopause transition. And it's especially useful for people who lose estrogen prior to that period of natural menopause transition. Let me see. Do we know if there are any cognitive changes for younger women outside the typical menopausal age? A woman in her 30s who has a hysterectomy was launched. Yes. So this is a very important point. So women who undergo early menopause, anything prior to that typical age, yes, have increased risk of cognitive symptoms. And it is strongly recommended for women in those cases to have hormone therapy. So if you have your ovaries removed, if you are in early menopause for natural reasons or for chemotherapy reasons, any women who go through early or premature or surgically induced menopause, yes, in those cases, it is very valuable to have hormone therapy. Of course, it also depends on the woman's other health history. So, of course, I couldn't prescribe that to you. You'd have to talk to your doctor about your specific health history, whether it's safe for you. But yes, in cases of early menopause, hormone therapy has been strongly suggested to be helpful for cognitive function in those women. Okay, so this woman says, I thought HRT is linked to many cancers. So that's part of that old, outdated, controversial information. So back in 2000 or the early 2000s, there was this big panic about a finding saying that it was related to breast cancer. Those results are over 20 years old and are very controversial, and people have spent a lot of time trying to undo the damage that was done by those controversial findings. So that the book that I mentioned, Estrogen Matters, is actually a recent and very helpful book describing who is at risk for cancer, who is not. And their conclusion is that for most people, it's not a great increase of risk in cancer. And those panic-inducing findings are, as I said, over 20 years old and are no longer considered the most up-to-date findings, although people still seem to believe those findings. So it's really important for people to have up-to-date information. Is there any natural estrogen? So that's a good question. So soy foods have something called phytoestrogens. So those are natural. They don't act exactly in the same way as the estrogens that are produced by our body, but they can be helpful. There are bioidentical hormones, which are considered to be more similar. But some people are not good candidates for taking hormone therapy. So those people might use a new drug that's come out called Veoza, which is useful for treating hot flashes and night sweats in people who cannot take hormone therapy. So those are some options for people that aren't able or willing to use hormone therapy. Where can I get info? Yes.
Dr. Watts, somebody sent me a question for you, so I wanted to ask real quickly.
Sure.
This person had a full hysterectomy due to uterine cancer when she was 50. She still had periods, although not on a regular basis. Her doctor said that she could not take hormones, and she's wanting to know, does this lead to higher levels of dementia issues?
So having a hysterectomy by itself is not an increased risk. What matters is the ovaries. So sometimes people have the uterus removed without having the ovaries removed. So the ovaries is where estrogen is produced. So as long as you have at least one ovary, you can continue to ovulate and continue to produce estrogen. So just having the uterus itself removed is not the same as having a full ovarectomy. So now, of course, different people have different risk factors. So, for example, people with family history of cardiovascular risk factors or people with breast cancer risk, those are things that you'd have to talk to your doctor about your specific risk factors. I can't say that, everybody who's had a hysterectomy should just take hormone therapy. That's not a responsible statement for me to make, because I don't know about the individual histories of people and what all the different risk factors they may have, what may be in their family history. But it's really the ovaries. As I say, you can have your uterus removed and still not be in menopause. It's the ovaries being removed that is what's associated with that early onset, surgical onset of menopause.
And this person did go on ahead and message me and shared that her ovaries were removed.
Mm-hmm. Yeah, so and different doctors are going to give different responses about whether or not you should be on hormone therapy when you have your ovaries removed. As I say, that depends on your individual history. There's a lot of good evidence that going on hormone replacement therapy after having your ovaries removed at an early age is beneficial. I don't know your individual medical history, so I can't say why that doctor said that was not a good option for you. But many women do take hormone therapy after ovarectomy and hysterectomy and find that it is beneficial for them. That's not to say that because someone has a hysterectomy, they're automatically going to develop dementia. It does put them at increased risk for some diseases. Now, also, I think you mentioned that it was at age 50. So age 50 is very close to the age of natural menopause. The issue here is when you are at reduced estrogen exposure at an early age, so 45, 40. At age 50, you're actually quite close to the natural age of menopause, so it's not quite as great a risk at age 50 as it would be, say, at age 40. I see another question about
Thanks, Amber.
cognitive effects of tamoxifen. Yes, so I am not an expert about cancer or cancer treatment. I know that cancer treatments do affect cognitive function independently of menopause, independently of dementia. So there's a whole other literature about cancer treatment and how it affects cognitive function. And I'm not really an expert on that subject. There is plenty of research out there about it. That's not my area of expertise. But I will say that the menopause.org, that website that I mentioned, has a lot of very useful resources for people about menopause and about estrogen. I know they do research about cancer treatment as well. So I'd say that would be a very good and reputable resource to look for, menopause.org. Someone's asking, can you name or link reputable studies to the effects of estrogen on Alzheimer's disease? There is a whole big literature about this. I will say there isn't any conclusive decision about this. There have been hundreds of studies looking at estrogen and Alzheimer's disease and how they may be related. The best I can say at this point is that it's unclear that taking hormone therapy is the way. The FDA does not recommend hormone therapy as a treatment or prevention for Alzheimer's disease. There are quite a few studies out there. There is one big recent meta-analysis by the first author's name is Andy, A-N-D-Y, and I think that's 2024, that shows that hormone therapy is not at all useful for treating Alzheimer's disease or preventing Alzheimer's disease, but people who do take it during the time of the menopause transition do see benefits in memory function and some other functions. Is it possible to take part in the study if I have already gone through menopause and am on HRT? Yes, so we don't exclude people on HRT. It does matter, though, how long you've been past menopause. So we are including people who are no more than 6 years past menopause, because what we're trying to do is compare women who are early in the transition, in the middle of the transition, and recently finishing the transition. So people who are more than 6 years past, we're not including in the study at this time. I think I got everybody in the chat.
You did. Wow. I had a question, Dr. Watts, that really kind of rose as I was looking at the criteria for the study, and I know that I met the criteria, so thanks for letting me participate. But I was wondering about men who might have all of those same eligibility factors, but they're men. Is there anything that men in this age group should be thinking about because of that transition from midlife to being old?
Absolutely. So what's interesting is when women go through menopause, they suddenly, their health looks a lot more like men because estrogen's been protecting women all this time, and now it suddenly isn't anymore. So women begin to have the same kinds of risk factors that men already have. So men's cardiovascular risk factors or risk of cholesterol or risk of diabetes already begin to increase in midlife, separate from the experience that women have when estrogen is no longer present. So yes, it's all of the same thing for men. You know, you want to control blood pressure, you want to control cholesterol, you want to manage your weight. You want to do things like healthy diet and exercise. And those are the best things that we know of that can reduce the risk. And it's not just good for Alzheimer's, you know, it's good for everything, right? So if we can keep those things under control, we have lower risk of heart attack, lower risk of stroke, lower risk of diabetes. So anything we can do to keep those things under control. And it's just the way of aging that once we get into midlife, that's when the pounds start racking up and it's harder to get rid of them. That's when the blood pressure starts going up, even though we're doing the same things we used to do. Yeah, so, you know, some of those things. So I mentioned a lot of healthy lifestyle factors, but sometimes people, even with healthy diet and exercise, they still have trouble losing that weight or they still have trouble getting that cholesterol down. I'm in that camp myself. The cholesterol is really hard because it's heritable in my family, and so I just have elevated cholesterol. So, you know, if you can change those through diet and exercise, that's wonderful. But sometimes it's worthwhile to go into your doctor and get some medications that help you keep those things down. So anything you can do to, you know, reduce those risk factors is going to be beneficial for your heart and for your brain and for your overall health and longevity as you age. All of those things are beneficial for all of us, not just for women going through menopause.
Wow. Okay. I just got a direct message. I think I know the answer, but if you have just another moment, Dr. Watt,
Sure.
we have a question that says, does KUADRC have, or is it contemplating studies for women in the post 65 age group who did not take estrogen in menopause due to recommendations?
Yeah, so to my knowledge, I'm the only person at the ADRC who's studying menopause right now. And I don't know of anybody else that's planning on studying menopause or estrogen at this moment. Right now, we're specifically looking at 40 to 60, right around that menopause transition. We are planning to some future grant applications to look at things related to mitochondrial function and menopause as people are getting older. I don't know of anybody right now. I'm the only menopause researcher that I know of at the ADRC right now. That doesn't mean that you couldn't find a good healthcare provider who could talk to you about that. We do. OBGYN at KU Med has a menopause clinic, which has some expert healthcare providers who you can talk to about all things related to reproductive health, related to menopause, related to hormone therapy. And they would be much more able than I am to help you work through your specific health history, your specific risk factors, your specific needs. So definitely seeing a healthcare provider who is well-versed and trained in menopause treatment is definitely a worthwhile endeavor.
Perfect. Thank you. I just dropped the link one more time in the chat for everyone. If you're interested in knowing more about the study, you think you might be eligible, etc. Gentlemen, I suppose it's okay for me if you're watching, if you know a woman who might fit the criteria, please help us spread the word. So often we're saying we need a few good or more than a few good men for our studies. And so we like to encourage your participation, but we also need you to help us, right? Dr. Watts, find.
Yep.
Our goal is 150, right?
150. And I
150.
definitely will say that for most of our trials, we have twice as many women as men enrolled. So yes, please do sign up for a study, even if it's not the menopause study. We have lots of studies where we have a hard time finding men to enroll, and we need more men. So please do sign up for a study that you might be eligible for.
Excellent. All right, folks. Well, thank you so much. I knew there would be a lot of good energy around this particular topic, so it's gratifying to hear it. Dr. Watts, I'm on the edge of my seat to hear what you learn.
Yes, and I'll be
from the
happy to come
study.
back once we have completed our data to tell you what we're finding.
That's what I was leading up to. So
Yep.
thank you. Thank you, everyone. I'll share that next week's weekly webinar, we will feature one of my former colleagues and one of my favorite people in the world, Laura Gilman, who is a licensed clinical social worker and a longtime person who has worked with aging communities and has now transitioned to doing a practice that includes talking about end-of-life doulas or death doulas, but end of life sounds a little more palatable. And so she is going to come and talk to us about her work in that area, and in particular, what we should think about in terms of our interest in brain health. So you'll see more information about that in the newsletter on Monday. I will use this great Wi-Fi out here in San Francisco to get this uploaded, hopefully really soon, in the next hour, maybe, before I go back to the conference. So this will be available to watch later today. And Dr. Watts will hold you to coming back and giving us an update. Thank you so much.
Sounds
Everybody
great.
have a great week.
Thank you, everybody. Have a good day.
Bye-bye.